And now I'm thinking about a long holiday without doing nothing. With doing nothing, but an emergency call of Dr. Hung has give me a new hope about this war. And now instead of having a sleepy lunch, now we're gonna have a sleepy dinner.
Yeah, sleepy dinner.
And okay. Okay, and this is my case today. This is a case that Dr. Lê Thanh Dũng gave us about a patient, 66 years old patient who have pain on the right hip. And is there anyone want to try it?
Yeah, I think many people, many students here want to show off your capacity.
Okay, can you point one?
No,
I want to give control for him.
You're a host, right? You are a host, right? And you can call Hà Khương, for example, pretty girl.
Okay. Okay, Khương, I have given you the control. Can you show us what do you see in that X-ray? Hello.
Yeah.
Hello, Khương.
As I can see a lytic lesion in the neck of the femur.
Okay.
It's not really clearly.
See?
Okay. So, can I ask how old the patient?
66 years old, male.
All right. Any clinical symptoms?
He had pain on his right hip.
Acute or chronic?
Just pain only.
All right. I can see a lytic, not really a lytic lesion, but a loosened lesion in the femoral neck of the femoral, and there is no ossification. With its margins cannot be seen clearly, and it might have soft tissue mass.
Okay, may have soft tissue mass.
Yeah, I think so.
At the upper side, right? Okay.
I guess it might be metastasis or some kind of fibrous lesion.
Okay, I think with what you have described, the first thing you can say that this is a case of this is an aggressive lesion, right? Because this is a lytic lesion, maybe Ludwig 3, which destruct the bone cortex and on the upper side, and have the soft tissue mass surrounding. Firstly, you have to think about the case of aggressive. Maybe it may be sarcoma, it may be Ewing or etc. But just think about an aggressive first, right? Okay, yes. And the second thing, what makes you think about this is a case of a met in here in the issue typical. Okay, I'm gonna stop sharing. Oh, sorry. First time. Okay. You see me? You see my screen?
Not yet.
Not yet. Okay. Let's wait. Sorry, first time.
Okay, and you should change your, your internet.
Change my internet? Change one?
Yeah.
Yeah, I'm in control.
Okay.
I'm in control. Okay. And the thing that makes you think about this is a mass in here in ischiotypical. You see a very subtle pathologic fracture. Just have a little bit of dislocation. Do you see it?
Yeah.
Okay. Is anyone see the fracture?
Yes, yes, yes.
You can, yeah, very subtle, right? Fracture on the right issue, tuberosity, right? And this is a case that this is a thing that make you think about maybe this is a case of metastasis, and this patient have his biopsy result, and this is a case of hepatic metastasis to the bone, and because of this, so today I'm gonna make my talk about bone metastasis. Okay, do you see my screen?
Yes.
You see? Okay. Okay, bone metastasis, an overview.
Yeah, can you make
The
it
first one,
full screen?
what? Full screen? It's full screen.
Yeah.
Okay. Okay, the first one, let's take a look at the study of Johns Hopkins University, a study of 334 cases about bone mets. And this is they study 300 cases about bone met in 5 years. And
oh, sorry, but I can see your the X-ray image. I can see your presentation.
You cannot see my presentation?
Yes, I just see the X-ray image. Can you show
it?
Can you show the presentation? Anyone else?
I'm showing it.
No, I can see. I can see.
My God.
Your slide. I can see your slide.
Okay. What happened with your computer?
You need to change out.
Yeah, I think I should change to a Windows computer instead of Mac. Yeah, but I don't see your presentation.
Okay. You see it? What can I do? Share it again.
Okay, say it again. Say it again, please. Why I
okay.
can't see your presentation? No, I just see the X-ray image.
Close it.
Yeah, just close the X-ray image, please.
You see it?
Yeah.
No.
Because of this.
Not yet.
Yes. I see the
you see it?
presentation. Okay.
Yes. Okay.
Let's go, Vazi.
Okay. All of you have seen it, right?
Yeah.
Okay. Firstly, let's look through a research about bone metastasis, a study of 334 cases in Johns Hopkins, and this is a result of this research, and you can see that in 300 cases, they find out that about bone metastasis, they find out that breast cancer had 100 cases, and prostatic carcinoma had 134 cases, and some of them, the other is hypernephroma or renal cell carcinoma, and the other is stomach melanoma, colon rectal and rectal carcinoma, and melanoma is small number. As you can see here, in 300 cases, we have 200 cases, or 70% is about breast carcinoma and prostate carcinoma. And you may have a question that why do the incidence of breast carcinoma and prostatic carcinoma metastasis to the bone is so high? It's very high. And we have a theory here about the mechanism of cancer metastasis to the bone. And they have the test here, a research here in 1940. Boston demonstrated an anatomy of this system by injecting the color diodes into the deep dorsal pineal veins and and show the network of Wallis vein in the human body. Mean that he inject the color diode in the penis, in the pineal vein and prostatic vein, and he figured out that the color diode, it can flow back from the pelvis to the vertebral. And what do you think? Is that a normal thing? Is that normal? No, of course it's not normal. Why? Because we know that normally the venous system had valves, right? it has walls to prevent the flow back, to prevent the retrograde blood flow from the lower part to upper part of the vein, right? But the specific about this kind of venous system is that the venous system which connect from the pelvic organ to the spinal cord, to the vertebral, it had no wall. So because it had no wall, the color condyle can flow back, and we call that wall-less system, venous system, or Boston venous plexus. And this is and because of that, they think about, oh, maybe this is the pathway for metastatic cell to metastasis from the pelvis organ, like prostate or like bladder, flow back to the spinal, to the vertebral, to causes the metastasis. And because of the location and lack of valves, they believe that to provide the route to spread the cancer metastasis from the prostate flow. It's not only the pathway for metastatic cell. Boston venous plexus may also spread the infection of similar manner, in a similar manner like urinary tract infection, like pyelonephritis, have been shown to spread to cause osteomyelitis of the vertebral via this route. And it has a route to metastasis from the pelvis to the vertebral. That's why the incidence of prostatic carcinoma metastasis to the vertebral is so high, because it had a route. And how about the breast cancer? Boston also inject the mammillary veins of female cadaver and found the venous connections between the mammillary and vertebral and the mammillary and shoulder girdle venous system, indicating a route for breast cancer to spread to the spine and the humerus respectively. It also had the other venous system to connect from the breast to the vertebral. That's why the incidence of breast cancer. Okay, is there anyone have your phone? Okay, that's why the incidence of the breast cancer and prostate carcinoma, which metastasis to the vertebral, is so high. Okay. Okay, is it clear? Is it clear? Is there anyone hear me?
It's very clear.
Do you understand it?
I got it. Yep.
Okay. That's the pathway for metastasis for cancer cell come to the bone. And now, when it comes to the bone, what happens? Let's review a bit about the bone cell. There are three specific types of cells that are found only in the bone. The cell names start with osteo. The first one is osteoblast. That's the cell from the new bone. They have only one nucleus. Osteoblast work in the team to build a new bone. It's just the immature new bone. The second one is osteoclast, as a large cell that dissolve the bone. Osteoclast is destroy the bone through the Ranyel system. They are formed in two or more cells that fuse together and used to have more than one nucleus. And the last one is osteocyte, the mature bone cell. And when the cancerous cell come to the bone, it activates the bone cell, and based on the type of the bone cell it activates, you can classify bone metastasis into three types. The first one is pure lytic lesion, which means that when the cancer cell come to the bone, it activates osteoclast cell, or the bone destroying cell, right? The second type is pure sclerotic metastasis, meaning that when the cancer cell comes to the bone, it activates osteoblast or bone destroying cell, and osteoblast or bone building cell, and it creates a sclerotic lesion. And the last type is mixed of lytic and sclerotic, meaning it activates both types of bone cell. The first one is osteolytic metastasis. They are the most common type and representing for about 75% of all metastatic lesions. The primary source usually a carcinoma of the kidney, lung, breast, GI tract, and thyroid. And you can see here, this is a case of osteolytic metastasis of thyroid cell. It is an osteolytic lesion, right, with internal tuberculation inside. The second type is osteoblastic metastasis. It represents for approximately 15% of all metastatic lesions. In men, they are caused mainly by primary carcinoma of prostate and seminoma. In women, the primary source usually carcinoma of breast, uterus, and ovary. And you can see here a lot of ivory lesion, osteosclerotic lesion, which caused by metastasis of osteoblastic. And this kind of metastasis is most commonly seen in prostate carcinoma and breast carcinoma. So next time when you see a multiple osteosclerotic lesion like this, if this is a man, think about prostatic carcinoma, and if this is a woman, think about breast carcinoma metastasis. The last thing is mixed of lytic and sclerotic lesion. They represent for about 10% of all metastatic lesion. The most common primaries being a breast and lung carcinoma. And you see here we have on L4 we have osteosclerotic lesion, and L5 on L3 we have osteolytic lesion with the osteosclerotic inside. This is a mixed type. This is pretty common in breast cancer, metastasis to the spinal. And you can see here, this is a table about most common tumor metastasis to the bone for about 80% of bone mass, and prostate mostly blastic or sclerotic lesion. Breast is mixed, lung is predominantly lytic, meaning that it has lytic and sclerotic also. Renal cell predominantly lytic. And the next thing to think about metastasis is distribution. Most frequently occur where the red bone marrow is found. It has been suggested that its distribution might be in relation to the hematopoietically activated red bone marrow. Bone metastases are almost always multiple and involved in axial skeleton. You see that most of the metastasis present in axial bone, like spine, like rib cage, like pelvis, like proximal of the femur, and bone metastasis and skull also. Bone metastasis to the foot or the hand or forearm is very rare. Proximal skeleton, axial skeleton, proximal segments of limb bones, extremely rare to distal of elbow and distal of knee. This is very rare. Mostly present as a central bone. But as I said to you, mostly the bone metastasis most commonly present in axial bone, in axial skeleton. But we have some kind of exception. This what we call acrometastasis. Acro meaning that distal pole, meaning that it's not present at the central bone. It presents at the hand and foot, at the distal portion of your body. Acrometastasis or metastatic lesions affecting the distal pharyngeals are extremely unusual. But if it presents, the primary tumor usually in the lung carcinoma. As you can see here, a lytic lesion which damages the bone cortex and causes a soft tissue mass surrounding. This is the case about lung carcinoma. About the radiographic features, actually there are no specific type. There are no specific feature for bone metastasis because we have 1,000 type of bone metastasis, and we have a based on 1,000 type. We have thousands of different kind of lesion for bone metastasis. But in very general, bone metastasis have a radiographic feature of skeletal metastasis, generally not specific. 90% of them are multiple. The first thing, the first that make you think about this is a kind of bone mass is multiple lesion. Solitary metastatic lesion may look just like a primary bone tumor and very, very hard to distinguish between both kind of entities. And the second thing make you think about this is a kind of bone mass is central presentation. Most likely it presented at the central bone, like your rib cage, your spine, your pelvis, and upper part of the femur. And it may appearance at the moth-eaten and pre-permeated. Most likely present a lot week 2 or a lot week 3, right? The kind of aggressive presentation, or sometimes it present a geographic lesion. But you know that but in case of bone mass, normally geographic lesion mean that this is lot week 1, meaning that this is a kind of benign lesion. But in case of bone mass, even if present the geographic lesion or lot week 1, this doesn't mean that this is a kind of benign lesion. This still aggressive, it's still growing, and in very common, it has no periosteal reaction. It's very different with osteosarcoma, right? Because osteosarcoma usually present with periosteal reaction, but in case of bone mass, it usually had no periosteal reaction, may have soft tissue mass or not. This is not a specific type. And pathologic fracture and spinal cord compression may also pretty common. Okay, last time I have talked to you that most likely bone mass present at the central. Most likely bone mass present at the bone marrow. Most likely bone mass present at where we have the red bone marrow, where we have abundant blood supply. But this is the other specific type. We call that cortical metastasis, or it has another name, cookie by metastasis. It's an atypical location due to poor endothelial vascularization compared with endosteal area where it had abundant blood supply, right? Because the cortical bone had a very poor blood supply. But it can present like this, like some part of osteolytic lesion at the cortex of the bone, look like the cookie by lesion. The majority cookie by, we call that cookie by metastasis. The majority of cookie by metastasis develop from an airway carcinoma. The possible mechanism of distal spread of cancer cell, the mechanism may be to bone cortex, may be arterial dissemination through the unique vascular network originating from the overlying periosteum. And they think about that maybe this kind of the metastasis is unusual. It may be due to the blood vessel system under the periosteum, but they are not sure and about how and why. How can it present in the cortical like this way? It had very poor blood supply, right? And in here, this is another kind of cookie by metastasis. You can see multiple osteolytic lesion, but mostly it presents at the eccentric position, at the peripheral position, like this. This is kind of cookie by metastasis from bronchogenic carcinoma. The other specific type of metastasis is hypervascular metastasis. It may present on X-ray, it may present at ill-defined osteolytic lesion and may have an internal trabeculation, blowout appearance like this, right? An osteolytic lesion eccentric at distal pole of the femur with a swappable appearance, right? It looks very like a case of GCT. But on MRI, we have a labular structure with hemorrhage inside. But what specific about this kind of metastasis is that it has flow void, some round tubular structure, which has no signal on T2, which has no signal of flow void, and most commonly can be seen in renal cell carcinoma, thyroid carcinoma, or hepatic carcinoma. Most likely flow void metastasis present in renal cell carcinoma. And this is another case of renal cell metastasis with fluvoid appearance. As you can see here, is on the X-ray, in the case of osteolytic on the rib cage, which damage all of the bone cortex. On the CT, on the post-contrast CT, you can see some parts of hyper enhancement, like blood vessel. And on MRI, you can see some of tubular with no signal, tubular route with no signal, which represent for fluvoid, a case of renal cell carcinoma metastasis to the rib bone. Okay, let's talk a bit about MRI. On MRI, it's very sensitive to detect the bone metastasis, which is imaging modality of choice for assessing the metastatic spread in the bone marrow cavity. Because you know that the bone marrow cavity is where it has the abundant blood supply compared with the bone cortex, right? Extension of tumor from the major marrow cavity and involvement of surrounding structures. As you can see, okay, the signal on MRI is also based on the type of the bone met. With the case of osteolytic metastasis, normally fatty bone marrow shows a homogeneous hyper signal compared to adjacent muscle in T1. But in case of bone metastasis, it caught hyposignal lesion, hyposignal focal bone marrow signal on T1, meaning that the tumor has spread and replaced the bone marrow. Normally, it is hyposignal like this on T1, right? So when the bone mass comes, it replays and destroys the bone marrow and causes the lesion of hyposignal like this, like this, like this, and like this. This means that the tumor spread and replace the bone marrow. On the T2, you can see hyposignal on steer due to hyperintense increase the content of water or edema. Like this, on steer, you see the hyposignal lesion, which means for bone edema. And lastly, after gadolinium administration, the vital bone metastasis usually show the contrast medial uptake, which can have the ring-like appearance. Okay, lastly, we have a specific, maybe a little bit of specific, and you can see here on the post-gadolinium, you see the tumor which have the hyposignal at the center and have a ring-like hyper enhancement at the peripheral area on post-gadolinium, like this, right? Central necrosis and hyper signal on post-gadolinium, ring-like appearance, which is pretty common in bone metastasis. Okay, do you got it? You get it? Is that clear?
Yeah.
Hello.
Yeah.
Okay. Next is about osteoblastic metastasis. You see here on X-ray, you have a case of osteoblastic lesion, ivory vertebral. It show the hyposignal on T1. And on T2, it show hyposignal also due to denscoric lesion to hyperintense when more cellular components are present, meaning that the signal on steer it based on the type. If this is osteoblastic, if this is have a lot of calcium, it will show the hyposignal on steer. But if it had more soft tissue component, it had more water component, it will show hyposignal. And on gadolinium, nothing special. Maybe we have a little bit of hyper enhanced here, surrounding with central necrosis, ring-like appearance maybe. And the lastly is the mix of osteoblastic and osteolytic. See here on X-ray, on CT, you see the osteoblastic lesion in here and here, and some kind of osteolytic lesion in here. On X-ray, on MRI on T1, it's similar what we see on the osteoblastic lesion will show hyposignal on T1, hyposignal on T2, and ring-like on post-gadolinium. So osteolytic lesion will show the hyposignal on T1, hyposignal on T2, and ring-like appearance with central necrosis and peripheral hyposignal on post-gadolinium. Okay, now is take-home message. The firstly that there are no specific sign for all kind of bone metastasis, but some kind of them have, but some kind of them have specific time we should care about. The first one is most multiple osteoblastic lesions are most likely come from prostatic and breast carcinoma. So when you see a multiple osteoblastic lesion, if this is a man, think about prostatic carcinoma. If this is a woman, think about breast carcinoma. Flow void metastasis mostly represent for renal cell carcinoma, and metastasis in appendicular skeleton or cortical bone more likely present in lung or bronchogenic carcinoma, where it has very poor blood supply. Okay, I have some case for you to practice. Okay, do you see my second screen?
Before we come to the the case study, you have anyone have any question for speaker? No question at all. Very clear presentation. Okay, so we can practice the clinical case now.
Okay. Okay, is there anyone want to try? I'm gonna give you control of the screen. Okay, what do we have here? Okay, how about Vân Anh?
With Vân Anh, we have
Dr. Vân Anh.
We have two
Cloud Duck, Vân Anh.
Yeah, Cloud Duck.
Hello chị Thanh.
Nhưng chị không điều khiển được màn hình thì chị ấn nút số 2 kiểu gì?
Ở đây để em share screen cho chị. Em chưa xem.
What the fuck?
Cloud
English, please. Cloud Duck.
Okay. Okay. I've given you. Okay.
Yes. Okay.
Yeah.
Keep in.
What the hell? So in this pelvis AP view, I see maybe the pathological fracture, because we see the fracture of the proximal part of the leg femur, but on the base of the bone you can see the mixed lytic with lytic express the sclerotic in the what is this iliac bone. The I don't remember name of this in English. I don't know. We see the cái gì gọi gì nhỉ? Ngành trên sông Vu. I don't remember name of this.
Pubic bone.
Pubic bone. Oh, yeah.
What is pubic bone?
Pubic
bone.
Yeah.
Pubic bone.
In the iliac bone, as well the pubic bone, you see the multiple lytic lesion. It's maybe the log-weak 1D. 1D means that you see the lytic region with no sclerotic ring, as well the sclerotic in the right iliac bone, and as well in the left femur. So it is the male or female? I think it's female.
Okay.
I think.
Click on the first.
Yes.
65-year-old female, right? So what do you think?
I think about my diagnosis is pathological feature. No, pathological fracture in the mixed lytic and sclerotic bone lesion. Maybe it's a metastasis from breast cancer.
Okay. We have number 3, right?
Number 3. What is
Okay.
CT?
Use it.
I think in this city not contrast in the axial bone window, we see clearly the lesion in the bone in the iliac excavator pelvis, but we still is the multiple lytic lesion in the vertebral body. Yes.
Okay.
Okay.
It do not change your idea, right? Do not change your diagnosis, right?
Let me see on the city. Why like this?
What do you want to do?
Click on the image once again. One again. Yeah. Okay, that's it.
I still think it is the metastasis bone, but maybe it's not from breast. It may be from breast cancer or lung carcinoma. I can tell you exactly where it comes from, but I still know both for pathological with the metastatic bone.
Okay. So this is a case of multiple lesion, right? Mixed sclerotic and lytic lesion, which present at the axial, as a central bone, right?
And do you want to take a look on the the soft tissue window?
Yeah, but the time.
We have soft tissue window.
Bravo, abdomen window for broad abdominal. Okay. The female. So
female.
I think it's now I don't see any specific here because it contains just some a part of the large and small power excrete, the bladder and the uterus. Some calcification in the uterus, but it doesn't make any sense. Huh? Yeah.
Okay.
I don't see any bowel wall thickening, so no GE tract carcinoma.
No GE tract carcinoma. Okay.
Yeah.
So this is a case of mixed osteolytic and osteoblastic lesion at the axial skeleton. As an axial skeleton with so most likely we think about prostatic and breast cancer, right? And this is a female, so most likely we think about this is a case of breast carcinoma, right? Okay. This is with some multiple lesion with some pathological fracture. This is a case of breast cancer. That's it. Okay, next case.
You can turn on by control.
Okay. I'm gonna give you. Okay. Is there anyone want to try next? Okay, how about chị Huệ? Hello, hello.
Wow, an expert from K Hospital.
Sorry,
Yeah.
Z, I'm using mobile phone. It's hard for me to using remote control.
Wow, the good IQ.
Okay.
The good IQ.
Sorry, Z. Sorry, Dr. Hùng.
No worries.
Okay.
No worries. It's not a big deal.
Okay. How about chị Minh?
Huyền, for example.
What? Huyền. Okay,
Yeah.
Huyền. Phạm Thu Huyền.
Yeah, talkative girl. You know, a lot of idea in her head.
Okay. Hello, Phạm Thu Huyền. Oh, actually, I don't know. This is the 45 Huyền or 43 Huyền.
Dr. Min, the Huyền come from Bạch Mai Hospital.
Yeah, from Bạch Mai Hospital.
Okay, I don't know. Sorry, but
I think
anyway,
her is off.
try it.
Nhầm hết tên rồi thầy ạ, nên thôi thầy ạ.
Đây, iPhone. Okay.
Okay, so can you take the case, Huyền?
Nhưng mà em không điều khiển được, em đang chỉ có điện thoại thôi.
Okay, so you find an excuse. How can you help her?
Okay.
Can you help your friend?
Hello.
Hello, Bùi Thảo.
Dr. Thảo.
Yes, Bùi Thảo. And you can ask for your, you know, your help from your roommate, Thảo. A senior doctor from St. Paul Hospital.
Hello, chị Thảo.
Hello, chị Thảo.
You
Hello,
hear me?
Thảo. Can you turn on the phone, please?
Teacher Thảo.
No, I don't have a microphone. Okay, Phương, raise your voice.
I also don't have a laptop.
Your phone.
I use your phone.
Okay,
Sorry.
oh, that's good. Okay, Thị.
Hold up.
VA, right? VA.
Yeah.
Can you give control to Thị?
No,
Yeah,
I
have
still
given to VA.
Okay,
Is that
VA.
VA, right?
Yes.
VA.
Another pretty VA.
But I can control the mouse.
Can control. I have given it for you. Let me share it again. VA. Okay. Can you control my screen?
Anyone see my mouse?
No. Can you control my screen? I've given it for you.
Okay.
Okay.
First of all, I see the mouse on the left lung. Yeah, here, and in the deep.
We're taking X-ray of left shoulder.
Yeah.
See the X-ray.
For
Left shoulder X-ray.
Mass of lung. And the deep. I see the U-define on the from 4 to the 7 U-define, and this is the lytic lesion.
Lesion.
And the multiple of the of mass in the lung.
Now.
In here, maybe.
Okay.
So I think
you still have a number 2 and number 3. Why don't you try it? Number 2, number 3.
Number 3.
Yeah. In here.
Click on the number 3. MR. Yeah, no, MR.
Oh. Oh.
Yeah, maybe it's a scapula. I think
scapula. Okay.
How can I small?
Small. Okay.
Yeah.
Sorry. Okay.
On the T2 facade, the lesion in the scapula, a hyper signal on the T2 facade, and a hypo on the T1, and sorry, this try to the cortex.
Is there any specific feature in this case?
Maybe the joist, the still intact.
Joint still intact. Okay. I've talked about some kind of specific type of metastasis, right?
Do you see the a kind of specific feature in this case?
It is the
original of the
osteolytics.
Okay, osteolytic.
Anything else?
On MR, we have some kind of specific type of bone mat in here.
Anyone see the specific feature in this case? I think on the coronal T2 facade. Phương, can you see anything?
Is a flow void?
Yeah, I'm done. Yes, raise your voice. And make sure that the dog of your neighbor is sleeping.
Still, sir.
Lá?
Yeah. The dog is still not dead.
Con đang học zoom.
Okay. You need some exciter for this.
Vâng. Hello.
It is. I think it's a typical like a tubular shape with the hypo signal inside the mass around here. I think so.
Yeah.
Kind of a flow.
Low void, right?
Low void, right?
Okay. So what is the origin of the mass of the metastasis? RCC. Yeah.
Renal cell carcinoma.
But I have a question. And what about the tip?
I think the lesion at the rib and at the lung is metastasis as well from the RCC, from the kidney. No, do you think so, Duy?
I think he lost.
Yeah, he's out. Okay, so I think we have another presenter. Tick, are you here? Hello, Tick. Do you hear me?
I do.
Yeah. Okay. So I give you the host and can you show us your presentation?
Okay.
How can I give you a host? Zuzi, can you give him the host? Because you are host now. You are host now.
I'm host now. Okay.
Yeah, you are host now. So you give take. Okay.
Oh, okay. So are you there, Zui?
Zui, where are you?
Oh,
he's out.
Okay, fine.
Yeah.
I just want to give him a compliment for his presentation.
Okay.
And, yeah. So it makes me a little bit embarrassed because my presentation is not as good as he does. It's very easy. Okay, so I will do it anyway, and I hope it does not make you disappointed. So the topic is about SNAC and SLAC. They are two complications of scaphoid fracture. In fact, a fracture.
Can you make screen take? Sorry.
Okay. Sorry. My bad. Okay.
Okay.
In fact, a fracture in the scaphoid can lead to four complications. The AVN, the humpback deformity, SLAC, and SNAC. So some of you might ask why I single out these two conditions. And for your information, the SLAC and SNAC share some common features in their pathological pattern, and their names are pretty similar to each other. So I think it would be easier to keep in mind if I take the 2 out of 4. Okay, so let's take a look at the anatomical X-ray of these two conditions. As far as I can see, sometimes people would struggle to just to name the bone in the wrist. It is a quite complicated structure with 8 bones. But I think we should pay more attention to the 3 friends here: the lunate, the capitate, and the scaphoid. And because I have having a very hard time figure out these bones, so I came up with a tip, and some of you might find it very stupid, but I hope it can help. So look at the lunate. The lunate in Vietnamese term is nguyệt, and it refers to the moon. So the moon is in the sky, so it has the highest position. So find the bone which has the highest position in the wrist, and it may have high possibility of being the lunate. So we have first the highest, and next the capitate. The capitate in Vietnamese term is Ca, and it refers to the big brother of the family. So the big brother of the family have the biggest side. So the second one, we have the biggest. And the scaphoid is the bone which has the shape of a boat. I don't know how to put it, but I think it is the longest bone in the wrist. So we have the highest, we have the biggest, and we have the longest. So I think that's enough for the the look at the anatomical. Because as far as I can see, most of the injuries or dislocations are related to these 3 fronts. So okay, so later you will have your opportunity to put this knowledge into practice. First, the SLAC. is standing for scaphoid lunate advanced collapse. In simple, it is a collapse. Well, it is a collapse. Sorry, collapse caused by an abnormal between the scaphoid and the lunate. You can see here and compare it with the normal X-ray. It is pretty obvious that the space between the scaphoid and the lunate is widened. So it is an instability, and it is caused by the rupture at the ligament between the two bones. So it's like a rope which holds these two together, and when it is cut, these two became far away from each other. It is an instability, and that's the first word I want you to keep in mind. And this changing in position of the three bones caused to another pathological condition. It is the osteoarthritis. Well, it is quite complicated, but in simple measure, I think it will go like this. Normally, the wrist is designed to bear the forces between the forearm and the hand. So look at this. When a force from the radius come to the wrist, it will come to this point of the scaphoid. But when the position is changing, now it comes to this point. I don't know for sure, but maybe the bony structure between this position and this area is different. Maybe this one is much more stronger. And I think that's the reason why the osteoarthritis is start to take place in this area. And just like this, in the later stage of the collapse, osteoarthritis spread it throughout the wrist and causing the collapse. It's very hard for me to put it into detail, but I try my best. So it is the staging. As I have told you, the connection between the radius and the scaphoid is the first place where the osteoarthritis start here. And through little by little, it would spread to the whole articular surface of these two bones, and then it'll be in between the capitate and the lunate. That's it. The SNAC, the scaphoid non-union advanced collapse, is much more easier to understand. It is a non-union, sorry, misspell. The scaphoid in this case, it split it into two segments. And it is different from the SLAC that the ligament between the lunate and the scaphoid is preserved. So now one segment of the scaphoid would move along with the lunate, and the other would have its own orbit. So look at this X-ray and recall the tips I have given you at the first presentation. Now we can see that this bone have the highest position, and it is the lunate. This bone is the biggest one, so it is the capitate, and this is our scaphoid, and it is split into two. This segment would move along with this lunate, and this segment would go free. It has its own orbit, and because it has its own orbit, the articular surface, which is designed to bear the forces, would be changed, and that would cause the damage. In the first split, in its own structure, and then spread it into the whole wrist. Yeah, so this is the staging. So yeah, the arthritis as the radio styloids. So because this, this segment is go free, it do not attach to any other structure, so it will cause damage to these surrounding structures, and the styloid of the radius is the first victim, and then it spread it. That's it. The staging, I don't know for sure, but in clinical cases, I think that the staging is, it's not as suitable with the imaging, but you will see it later. So take home messages. If you see the risk in which the scaphoid and the ligament become separated from each other is a widening in the space between the two bones, think about the ligament, and the ligament is the letter L, and the letter L is will refer you to the SLAC. And next, the splitted scaphoid, it is a non-union. It is pretty obvious. So non-union is the word N, and the word N will refer you to SNAC. That's it. It is very easy. And now this is a clinical cases. You want to try first? I think you should give the order out, Mr. Hu. I think you should give the order because I think you know your residents well, and I think you would know who would be suitable to answer the question.
Okay, so I will ask, the 45. Why not, Triệu Quang Tĩnh?
Sorry?
Triệu Quang Tĩnh?
Oh. Yes.
Okay, take the case 1.
Okay. So remote control, right? Triệu Quang Tĩnh?
I think you don't have to give the remote control because it's just, the X-ray image, right?
Yeah, but
we don't have to move the slices.
Okay, so in case Triệu Quang Tĩnh want to, make any changes to the images, just text me. Okay.
Okay, that's good.
I don't control mouse.
Okay.
Yeah, what do you want to do?
Okay. So I will give you the mouse control. Triệu Quang Tĩnh.
Yep, Triệu Quang Tĩnh.
That's it. Will you take it? Is it working?
I also don't control.
It's just X-ray. If you don't want to zoom in, just ask him.
Okay. So I will zoom. I will make it bigger for you. But which one? Which one do you want to see it more obvious in a bigger size?
I think the first one, the IP view.
Okay.
We should begin with the IP view.
The X-ray is obvious to see, and on the IP view of my free X-ray, I see
osteoarthritis, right?
Yes, osteoarthritis.
First of all, the osteoarthritis.
The question is very easy. It is an SLAC or SNAC. Just 50% answer.
I think this IP view so
at LAC L.
Yes,
L.
SL.
Yeah.
At
SLC.
At LAC.
Why? Can I ask you why?
Because the scaphoid bond is intact.
Wow. Okay.
Scaphoid. Do you think so?
Yes.
How about
I think scaphoid bond in this film is intact. Yes, this is scaphoid bond.
Yeah.
okay? So anyone else have another idea? Or
So okay.
I can see lateral view.
Yes.
Yeah.
Of course, as you wish.
Lateral view.
Uh,
This one is the oblique view, right?
Oblique. So sorry. My bad. Is the oblique views? Yes. This one is lateral view.
Wow.
Actually, I think it's any information.
Lateral views less clearly.
You want to come back?
I think the best view is IP view.
IP view is
yes.
Is bad. I think it's the RLAC.
Okay, so can I have a follow-up question for you? Yeah, so you call it a SLAC. I agree, because your reason is that the scaffold is intact, right? But I think the space between the two bonds, do you think it is widened?
I think space between scaphoid and lunar is widely.
So what is normal distance between the bone of the wrist? Do you know?
I think space. I think space between scaphoid and lunar is wide.
You know the normal gap between the wrist bone is 2 millimeters for all kind of bone.
Sure. So okay. Okay. So your answer is right. This is a SLAC. And as I said, it is very easy because we just need to look at two features. First, the space between the two bones, and second, the anatomical feature of the scaffold. So the first clinical case is quite easy, but the second one would be much more challenging. Okay.
Yes. Thank you.
Okay. You got an excellent answer. Well, teacher.
Yep.
I think you should call a name.
Yeah, you asking for the next victim, right?
Yes.
Okay.
It's not victim.
Okay, so I choose Hải Anh.
Okay, I'm here.
Okay.
So next slide, please.
This is for you.
Oh my God. We go see on the AP view. On the AP view, just of this case, scaphoid, and the triangle shape is like pizza piece cake shape. So it may have an lunate dislocation and a very on the or you hear me well? Like I just out in connect for a minute.
Okay. I can hear you.
Oh, which part? There in
Can you repeat it?
Dislocation. Lunate dislocation.
Okay, lunate dislocation. I got it.
And scaphoid lunate disassociation.
Okay. That's the point.
And
okay, that's the point.
There osteoarthritis of this scaphoid. Can you hear me well?
So SNIC, right?
So your final diagnosis is? I think her connection is lost.
Yeah, okay, she's out. And I think we can see the a gap between the lunate and the scaphoid. Is you know, and I think this one is an example of scaphoidiness, this association.
Yes.
And you can see the you know, osteoarthritis between the scaphoid and the radial style.
Yes.
Stylo, right? And something else. So it's maybe the state one.
SNAC.
Okay.
State one.
But before we stage, before staging, I just want you to give the final diagnosis of this case.
No, I haven't done yet. Like I don't
go on.
The scaphoid had a well shape, so I want to look on other view to make sure the scaphoid have a well shape, not like have a chance scaphoid fracture or something.
Okay, as you wish. So you wanna
move the neck lateral and oblique. Oh, okay, oblique as well. Yeah, I see, and lateral as well.
Yeah.
I think that there a fracture of scaphoid, scaphoid. So it's maybe scaphoid, chance scaphoid, lunate dislocation, chance scaphoid fracture with lunate dislocation.
On the lateral view. Take a look.
I haven't seen the lateral view.
So in
this there, it must have.
Okay.
So I think it's kind of mix between two kind of lesions.
Yes.
Can you show us the lateral view? So in this case, I think the big brother is, you know, the posterior my you know, posterior dislocated, and with the lunate is, you know, a little bit this posterior is, you know, dislocated as well.
Oh yeah, so you wanna refer to the DIVI, right?
No, it's my capo dislocation.
Okay. So you know, the actual answer for this case is the mix between the SNAC and SLAC. Hi Anh, you know, you're very smart. So the space is quite obvious, and some people would end their thinking right there. But if you take more attention with the scaphoid, you will see that its anatomical feature has some, abnormals. And the final answer for this guy is the mix between SNAC and SLAC. Very good answer, I have to say. So we move to the last questions.
Pseudoarthrosis, scaphoid. Lộc, can you take this case?
Oui.
Vas-y. Tu vas parler français?
Oui. Un petit.
Mais tu vas parler français, toi?
Oui, c'est à mon avis.
How do I say French?
Il y a certaines lésions. Premièrement, il y a augmenter la distance de c'est le
Donc à ton avis c'est quoi ça? C'est le snack or slack?
C'est le snack.
Et pourquoi? C'est une augmentation entre les deux os, les scaphoïdes et les lunettes. So so he think of SNAC because of the increasing of the gap between the lunette and the scaphoid. What do you think?
No. S'il y a augmenter la distance, je pense il y a yes,
slack. Okay. Oh, sorry. Pardon. He think of this SLIC, not NAC, SLIC, because he said that is the gap between the lunette and the scaphoid. That's the reason why he think of SLIC. What do you think?
Can I ask you a question? So I think the teacher should be the translator between me and fellow Lộc.
Okay.
So my friend, can you name the bone? Just name the bone in this
Pardon. Je pense que c'est la leçon de snap.
Okay, so this one, what is its name? What is its name? This one.
Nunatum. Nunatum. Lunate. You can say lunate.
C'est la lune.
Okay.
La lune.
So what is this? So the lunate is here. It this shape, or so what is the outside circle? What is this? They look like a bone, and you remember that the lunate is not as big as this one.
Okay.
So what it is? What it is? What it is?
It is a small proximal, a segment of scaphoid.
Yes, this is actually the combination between the lunate and the proximal segment of the scaphoid. The scaphoid in this case is split into two pieces, and this is the proximal segment, and this is the distal one. So the correct answer for this case is SNAC. That's yeah, that's it. That's it. The end of my presentation. And as I have told you, it is very easy from the article to the clinical cases. And okay, so thank you for paying attention. That's it.
Okay, thank you very much. And I think that's, even though it's a short presentation of SNAC and SLAC, a common complication of the scaphoid fracture, but it's good to know about how to make the diagnosis of two kind of complication. And after two presentation tonight, I hope that you can sleep more well than normal. Okay, and I really I'm very appreciate if if you want to join us on in this kind of sleepy dinner stuff for the next time, and we can organize together, because it's like it's like the normal thing that we do every day in our hospital, but we do it in a different way. Okay, yeah. And I think it's kind of it's kind of new thing is interesting than I thought before. Okay, so okay, thank you very much for interesting presentation, and have a good night and see you next time. Bye bye.
Yeah, see you later.
See you.
Thank you so much. Can I ask Dr. Can I ask something?
Okay.
I think that you're having dinner.
Tonight, at tomorrow night, can I give some presentation?
Okay, that's good. Yeah, we love you. Love you.
Very good.
That's great.
Okay, thank you.
Thank you so much.
Bye.
12 p.m. right? Or 11 p.m.
No. maybe like tonight.
Okay, after dinner. Okay.
Yes.
The next evening.
Okay. Good night.
Night.
Bye.
Bye bye.